Alright, online people, we just watched the vitamin video that's there linked. Yes. Okay, so on to the urinary system, Today we have class. You have a quiz. It's great. On Tuesday we have class. I actually have a question about this for you. So, because of how the semester is, there's one more day that we get to use than I was expecting, if that makes sense. I was planning on just taking today kind of slow. We finish wrapping things up on Tuesday, and then a week from today we do our review. If you want, we can move on to the reproductive system, mostly because there are so many misconceptions about the reproductive system, including ones that you think, so many misconceptions. Who all's here next semester? Okay, some of you? Okay, sorry, in this class? Some of you? Okay, well, we're going to spend like a whole week on things people think about the reproductive system that are wrong. Sorry. And like, yes. But if we want to, we can start next week on that, or we can just like finish up the urinary system, wrap up any loose ends. I am happy either way. Makes no difference to me. Thoughts? Cool. Okay. So we have class today, we have class Tuesday that's going to wrap up the urinary system, and I'll look through and be like, are we missing anything from the rest of the semester, like little chunks? And then a week from today we have a review, and if you want to, you can take your exam, and then you have the exam right before you leave for Thanksgiving, and everything's good. Right?
Do we have anything else for lab before we go home?
Before you go home, you have, on Tuesday you have your lab exam. Yeah, the next Tuesday occurs, sorry, I have a problem with next, like we're driving, and people like, take the next exit, I'm like, does that mean this one? Sorry, it's a thing I have a problem with. But yes, on Tuesday you have your lab exam.
Is it going to be taken like at the front classes?
So because it's not finals week yet, I'm just going to open it the whole day. But yeah, our lecture final, which is like worth 30 points, that one we have to do during our class time. But yeah, the Tuesday's exam will open in the morning and it'll close at night. But take it during your time if you want to. That would be the most sensible way to do it. Okay, so just to put through, we started this, we hadn't finished it. Urinary system's great. It's going to do a bunch of things. So we're going to look at these things in the kidneys. It's going to activate some vitamins. It's going to regulate water volume. It's going to maintain balance. It's going to do lots of great things. Lots of parts to the urinary system. Well, not as many, like 5 basically. But kidneys are really where it's at. Like everything else is basically just tubing. And the kidneys are what are doing interesting things. And so we saw the picture. This is where they're at. This is where it's at. And you don't want your kidneys to, like, fall down. Okay. I'm not sure why this is cooler than just a picture on the board, but it's cooler than just a picture on the board. Also, as you leave, if you want to go poke around it, you can look at it. Hi, online people. This is our kidney, right? Or one of them, cut open. And there are a couple parts to look at. I'll go pictures in just a sec. You can see how there's like this part in the middle that's basically a funnel. It legitimately is a funnel, sort of. There's this part that's like deep and looks different than this part right here. See that? These are the 3 main parts that we're worrying about. This is called the renal, and they're all named after other parts of the body, which is kind of frustrating. Well, not after, but similar to. This part right here is called the renal cortex. We've had cortex in the brain, we've had cortex in hair, we have cortex. It means bark, it's the outside covering. Cortex. We've got the renal medulla. It means like marrow, like inside. It's not bone marrow, but the goo in the middle here. And then this is the renal pelvis. Nothing to do with this pelvis, everything to do with it drain stuff. So far so good? These parts are blown up into this. Okay. Oh yeah, cortex, I'm doing a little pelvis. Huh. Here we go. Okay, picture, and it legitimately looks like this. It's one of the few parts that, like, often in anatomy, you see the diagram and you're like, yeah, I see the boundaries. I see the boundaries on the diagram, but looking at the actual structure, it's hard to see them. The kidney, it's easy. You look at it, you're like, yep. The outside coating, the inner bit, the drainage tube. Right? So, you'll also note, just as we're looking at this, we'll see more later. You see, there's a fair bit of blood supply, right? There's blood supply coming in and blood supply going out. So, tons of blood. Do not get stabbed in the kidneys. Don't get stabbed anywhere, but like, kidneys are a bad place to get stabbed because there's so much blood there. We're talking a quarter of your cardiac output. Kidneys aren't that big, right? They've got like a fourth of your blood hanging out there each minute. This is a lot of your blood. Don't bleed in your kidneys. This is a problem. There's also a bunch of nervous system fibers. Here, should look at this. It doesn't show it here. That's okay. A bunch of nervous system fibers that are going to hang out with the kidney. The kidney is going to act as a filter. You've heard this before? Kidney is a filter, maybe? Okay. We're going to see how that works in a minute, but I have this handy-dandy video of if your kidneys aren't working, people do dialysis. You've heard that before? Right? Fair. We're going to watch a brief patient educational video about dialysis. I have this new way I think will work to show it to the online people at the same time. We're going to try. It's the end of the semester, and I'm only now just figuring this out, but there's always next semester. Question. Are people emotionally, psychologically, physically prepared for next semester? Because I'm wondering if it'll be like, yeah, we're in the groove, or if we're like, I am already exhausted and just getting more exhausted. Okay. If all of you have any insight into what would make it less, rough, I'm open to suggestions. Okay, just a second.
Introducing Amazon Halo. Halo goes beyond counting steps to analyze the intensity and duration of your activity throughout the day. And that's just one of the ways Halo helps you look at health from a whole new perspective.
Sir, we need a doctor.
You're talking about a first-generation American from the streets of the...
Your doctor may recommend dialysis, a procedure that removes waste products from your blood if your kidneys are not functioning properly.
Your doctor may recommend dialysis, a procedure that removes waste products from your blood if your kidneys are not functioning properly. Healthy kidneys filter out waste, excess fluid, and electrolytes like potassium.
Your kidneys gradually lose function, leading to an accumulation of harmful wastes and excess fluid
and sodium from the blood. These waste products exit the body through the urethra in the form of urine. If you have kidney disease, your kidneys gradually lose function, leading to an accumulation of harmful waste and excess fluid in your body, increased blood pressure, and bone or blood problems. Dialysis can also be done to treat acute kidney failure, which occurs when your kidneys stop working suddenly, or to remove drugs or poisons from your body.
your doctor will prepare a vascular access site on
In
your
one
body.
type of dialysis, called
Your doctor will create
hemodialysis,
either an
your doctor will
arteriovenous
use a
graft
machine
or an
called a
arteriovenous
dialyzer
fistula to
to
access
clean your
your
blood
bloodstream.
outside your body.
To begin,
Some
he
weeks
or
or
she
months
will numb
before
the
you
area
begin
with local
hemodialysis,
anesthesia.
your doctor will prepare a vascular
To
access
construct an
site on your body.
arteriovenous graft, your surgeon
Your
will make a
doctor will
small
create
incision in
either
your
an
forearm
arteriovenous graft
and
or
insert
an
a soft
arteriovenous
plastic tube
fistula
called
to
a
access
graft
your
to connect an
bloodstream.
artery to a vein.
To begin, he or she will
To
numb the
create an
area
arteriovenous
with local
fistula, your
anesthesia.
surgeon will make a small incision
To
in your
construct an
skin
arteriovenous
and
graft,
connect an artery
your
with
surgeon
a
will make a
vein
small incision
to
in
make
your
a larger
forearm
vessel called
and
a
insert a
fistula.
soft plastic tube called a graft
Once
to
your
connect an
vascular
artery
access
to a
site has
vein.
healed, your doctor can start hemodialysis.
To create an arteriovenous
To begin,
fistula,
your
your surgeon
dialysis
will make a
nurse
small
will insert
incision
2
in your
needles into
skin
your AV fistula
and connect
or
an
graft.
artery with a vein
Once the
to make a
circuit is set
larger
up,
vessel
your blood will
called a
flow slowly
fistula.
out of your body and through the dialyzer.
Once your vascular access site has
Inside the
healed, your
dialyzer,
doctor can
your
start
blood will encounter
hemodialysis.
filtering fibers
To
and
begin,
an
your
absorbent
dialysis
cleaning
nurse will
solution
insert
called
2 needles
dialysate.
into your AV fistula or graft.
The
Once the
fibers
circuit is
will
set
remove
up,
waste
your
and
blood will
excess
flow
fluids
slowly
and
out of your body
electrolytes
and
from
through
your
the
blood.
dialyzer. Inside the dialyzer, your
Your
blood will
clean blood
encounter
will emerge
filtering
from the
fibers
dialyzer
and an
and
absorbent
continue
cleaning
through the
solution
tubing
called
back into
dialysate.
your body through the second needle at your access site.
The fibers will remove waste and excess fluids and
When your
electrolytes from your
hemodialysis
blood.
session is complete, the needles and tubing are removed, and you can go home.
Your cleaned blood will emerge from the dialyzer and continue through the
In
tubing
another type of
back into your
dialysis,
body
your
through the
doctor
second
will use
needle
the
at your
membrane
access
lining your
site.
abdomen, called the peritoneum, to clean your
When your
blood without
hemodialysis
removing
session
it
is
from your body.
complete, the needles and tubing
Before
are
you begin
removed,
peritoneal
and you can go
dialysis,
home.
you will have an operation to implant a soft tube called a catheter.
In another type of
Your
dialysis,
surgeon will
your doctor
insert
will
the
use the
catheter
membranes
through your
lining
belly
your
button,
abdomen,
creating a
called the
port through
peritoneum,
which the dialysate
to clean
will
your
enter
blood
and leave
without
your
removing
abdomen.
it from your body.
Each peritoneal
Before you
dialysis
begin
session is
peritoneal
called an
dialysis,
exchange.
you will have an
First, you will use
operation
your
to
catheter
implant a
to fill
soft
your
tube
abdomen
called a
with
catheter.
dialysate for a period of time determined by
Your surgeon will
doctor.
insert the catheter near your belly button, creating a
Through the
port
peritoneal
through which the
membrane, waste
dialysate will
products and
enter and
extra
leave your
fluids are
abdomen.
continuously
Each
drawn out of your
peritoneal
blood
dialysis
into
session
the
is called an
dialysate.
exchange.
Along with the
First, you
waste
will use your
materials it
catheter to
absorbs,
fill your
the
abdomen with
dialysate will drain
dialysate
out
for
of
a
your
period of
abdomen
time
into
determined
a
by your
disposable
doctor.
collection bag during your exchange.
Through the peritoneal membrane, waste products and extra fluid are continuously drawn out of your blood into the dialysate. Along with the waste materials it absorbed, the dialysate will drain out of your abdomen into a disposable collection bag during your exchange.
Okay. Makes sense? We're okay with the concept? Basically, your kidneys are filtering your blood. If your kidneys aren't working, you just filter the blood a different way. Right? Oh, I didn't put this in, but it's kind of interesting. You've heard of kidney transplants, right? Okay. Does anybody know where... Okay, so you know where your kidneys are. Do you know where kidneys... If you get a kidney transplant, where they put it back in? You'd assume, like... Sorry, let me look this up just a sec. I should have put a picture. Yep. There. We'll talk about why in a sec. Yeah, so online people, this is the kind of picture we're looking at here. If you get, and so everybody, if you get a kidney, so if your kidneys are diseased and they're just not working properly, typically the docs are like, I mean, so long as they're not like actively causing problems, we'll just leave them there and not take them out, and we'll just put your transplanted kidney just, you know, down there. It works, apparently. But yeah, anyways, it's just interesting to me personally. Okay. While we're at it, people who really need their kidneys. For all I was yapping about, like, this organ is optional, that organ's optional in the digestive system, you have to have functional kidneys. If your kidneys aren't functional, you're going to need to be on dialysis, like, just pretty much forever. You have to be able to get rid of this kind of waste. Kidneys are overdone in the sense that, like, half of one kidney could keep you covered. If you lose one kidney somehow in a terrible accident of some sort and the other kidney gets damaged halfway, so long as you have half a functioning kidney, you should be fine. And so it's kind of like, I guess, over-engineered a little bit, like you got a lot of them, but you can't have all your kidneys fail. Like, you really, really need them to work. What is the picture here? Oh yes, this is to illustrate blood vessels. Do we see there's a lot of blood vessels going on here. Do we see that? Okay, so the kidney as a whole, we have blood coming in and blood going out. We're trying to filter the blood. The functional unit that does that, people totally already knew. It's called the nephron. It's this little thing. You've seen this before? Most of you, some of you? Is this news to anybody? No? Okay. Though the thing is, I do know it's news to some of the class, most of the class who's online hasn't had anatomy before. So, we're going to go over it, and I'm sorry if it's super boring. I hope it's not boring. But if you've seen it before, it's not going to be like, come on, open up, computer. There we go. Okay, so it's the structural unit that's actually forming urine. It's got two parts. This thing called the corpuscle, and then the tubule. This little guy here, that's our corpuscle, right? So, the corpuscle, we're going to just go through it first, has two different parts. One part is called the glomerulus. It's all Latin or Greek. It's either Latin or Greek for ball of string. And you can see why, right? It's this, it looks like a ball of string. It's got these capillaries. I had a picture. Oh, good grief. There we go. Actually, we'll get to it later. I'm trying to stay organized. We're going to go through the anatomy, and then we're going to go through the physiology. So, you've got these capillaries coming in that are leaky. It's called being fenestrated. They're leakier than normal blood vessels. So, this little bit is the glomerulus. You then have the glomerular capsule, which it's sometimes called Bowman's capsule, but it's the cup around the blob of yarn, right? So you have the glomerulus, you've got these leaky blood vessels, and then you've got the covering around it that's holding it. It's a capsule. Here at the glomerulus, so both the capsule and the blob, sorry, the corpuscle, this is where filtration's actually happening. So, like, you've seen filters on dryers, right? You have this, like, a screen mesh, the air goes through, when it gets stuck, you pull it out, right? You've had that concept. And filters, like in cars, work the same way, right? Where you, like, blow air through and you catch the gunk, right? That's a standard model of a filter, at least for me. Kidneys are filters, but they're not filters like that. They're not filters in the sense that you just have basically a screen and you run gunk through. For the screen running gunk through idea to work, you need to have big stuff that you want to keep out and little stuff that you want to let through, right? But what do you want to keep in the blood? Yeah. Are they big or small? Yeah, so, sorry, what did you say? I'm going deaf.
They're small.
They're small, but compared to, like, little tiny toxins? Yeah, right? So do you see the problem here? Sorry, online people, they're saying, yeah, okay, so you're trying to filter a bunch of small gunk out of the blood, right? But the relative sizes, like a red blood cell or a white blood cell, those are bigger than little tiny, like, environmental toxins you have floating around. It's smaller than, say, urea, right? Urea is a little chemical that's floating around that you want to get out. So having just, like, a mesh isn't going to work, right? Because, sorry, for the first bit works, for the second reason it doesn't work. So, yeah, you could keep red blood cells out because they get stuck on their mesh, right? And you could get other stuff through. But then you lose a bunch of salts. You don't want to lose all your salts. You lose a bunch of water. You don't want to lose all your water. And you want to keep some of the other small stuff, like certain vitamins and stuff, right? So what the kidneys are going to do, they're going to be a filter, but they're a filter more like they're cleaning out their backpack. Anybody here organized? Like, yeah, probably most of you. Anybody here, every year you're like, this year I get organized, and then you never do, but you're like, this is my year? Okay, I feel you. You have this backpack. Okay, I had this backpack where, as a student, I would get stuff done, I'd keep putting things in my backpack. And about once a month, my backpack was huge. I'd be like, holy crap. I dumped the whole thing out, and then only put back what I wanted. Does that idea make sense? Kidneys are going to do that. Instead of just having filters where you run some things through and keep other things out, they're basically going to dump everything out and then put back into the blood what they want to go back into the blood. Are you okay with that? So we say filtration, that's what we're talking about. A bunch of stuff is going to leak out of the blood, and then the body is going to put back into the blood the stuff it wants to keep. Alright, but sorry, I get distracted in physiology. The anatomy, stay on anatomy. The renal tube, it's this tube portion. It's about 3 centimeters long, so like, just longer than about this. So it's reasonably long. The whole tube from where it hits the corpuscle all the way to where it ends, it's a single layer of epithelial cells, but each different region is slightly different. So there are 3 parts, and the naming strategy is great, but kind of boring. People know what the word convoluted means? If someone has a convoluted explanation or argument, it's like all twisted up, it's not very clear. Yeah. It's named like this. It's named, so starting from the from the capsule, you have the proximal convoluted tubule, meaning the nearby twisted up tube. Any guess what this one's called? Yeah, it's the distal convoluted tubule. It's the far away twisted up tube, right? Yeah. The one in the middle is called the nephron loop. We'll get that. And then it drains into what's called the collecting duct. So the proximal convoluted tubule is actively pulling back solutes from the tubular fluid. So stuff's going to come out, and it's going to actively try to grab stuff back. It's going to pull back nutrients, right? Amongst other things, you should not be peeing out your sugar. Don't do that, right? Your proximal convoluted tubule should be pulling back nutrients. It should be pulling back electrolytes. It should be pulling back plasma proteins. It should be like, no, none of this. Like, come back. this single layer of cells, but you can see, as you can see up there, there's a ton of surface area. Typically when you see things like that have a ton of surface area, you assume some sort of absorptive process is taking place. We're okay with that? Okay, then we get to the loop of, sorry, nephron loop. It used to be called the loop of Henle. This guy was amazing. He did germ theory, he did sharks, and he figured out the kidney. Which seems like an interesting combination of things to do, but like, he was on it. This loop is pulling back water and sodium and chloride. That's what's pulling back. These little guys are flat. We're specifically only looking at this thin segment part. There's a thick segment part too. But still one layer of cells, but really, really thin here. Then last but not least, there's that distal convoluted tubule. This one is interesting because it's actively secreting something. So then in the glomerulus, you're dumping out a bunch of stuff from blood. And then proximal convoluted tubule and the nephron loop, you're pulling stuff back in. In the distal convoluted tubule, it's actively putting out hydrogens and potassium, in case you need to get rid of that. The proximal convoluted tubule is always pulling back water. Like, it just always pulls back some water, because you don't want to, like, pee out all your water. The distal convoluted tubule can. It's going to reabsorb water and sodium. It's only doing that if you're dehydrated. We'll come back to ADH probably later, but just staying focused on the anatomy. We see the anatomy here. It's actually a fairly, for all its convolutedness, it's a fairly straightforward system, right? We'll look at it more in a second. Distal convoluted tubules, they're chubbier cells, they're fat cells, so forth. And you can actually see, yeah, we have it here. You can see the corpuscle, right? You can see that there's this glomerulus is kind of a mess in the middle, looks like. And it's hard to see because of the cut, but this part right here, online people here, this is the distal convoluted tubule, and this right here is the proximal convoluted tubule. It's tricky to see because of how it's folded. Okay, carrying on. Questions? We're doing okay so far? Okay. I can see everything and then focus on physiology. I'm trying not to get ahead of myself because I actually want to make this make sense, because it's a very elegant system, and it's one that's fun because it's self-contained enough that you can be like, oh, look at all the parts. Whereas some things, like the endocrine system, you're like, it's just all over the place, a mess. Okay, so the collecting ducts are going to be collecting the stuff that's coming out of the distal convoluted tubule. When it comes out, so it's tubular fluid when it's in here. When it comes out, it's now officially urine. Collecting ducts can, if you're desperate, they can actually pull back a little bit of water, but they don't usually do that. Here we go. Did I put that twice? Sorry. So here's the whole picture where, do you see where we're at in the kidney? We've got this little bit here. We have blood supply. And so we're looking at two different nephrons. We have blood supply in. It's going to come through the glomerulus. Filtrate, the goo, is going to come out. The blood that wasn't pulled out, the stuff in blood that wasn't pulled out is going to leave. That's fine. The filtrate, the goo now, is going to go through first the proximal convoluted tubule, nephron loop, the distal tubule, hit a duct. And this one over here is doing the same thing. Nephron loops can be slightly different sizes. There's this little short one here, there's this one that's big. But that's where they're at. Things to note. In this glomerulus, I realize not all diagrams are drawn to scale, but is the blood vessel going in or coming out bigger? Yeah, the one going in is bigger. Why? Yeah. Yes, absolutely. Okay, so, sorry, I feel weird like repeating what people say all the time, but it's easier for people to hear. I've had comments in my emails. So, yeah, not weird. You have fluid going in, right? It's called an arteriole. It's like a little tiny artery. You have fluid going in, and you want there to be some pressure behind it. Fluid's going to come out into that glomerular capsule space, right? So you're going to leave some. I need a stick. Well, you're going to have some leave. So there's going to be less fluid to send back. And what you don't want is you don't want stuff to just like pool and puddle. Exactly. You want to be able to have fluid go in, so blood come in and blood come out, and the tube leading is much smaller. Fair enough? Here's just blown up. You can see it's called filtration slits. They're pretty. Alright, there we go. Here's a better picture of actually what they look like. The little diagram is cute, but this is a better diagram. Yes. Nothing to show there. Well, oh yeah. Actually, something to show. We're going to see this later. If you're looking at the distal convoluted tubule, you'll see that even though it's one of the last things this tubular fluid, this filtrate, goes through, right? So as you're tracing it, stuff comes out here. This filtrate's going to go through the proximal convoluted tubule, hit the loop, come back up, hit the distal convoluted tubule. That distal convoluted tubule is right next, so it's something called the juxtaglomerular apparatus, just next to the glomerular capsule. It's right there, meaning there's a way for the nephron to use what's leaving to talk to what's coming in. Does that make sense? Because you want to adjust how much you have coming in based on how much you have going out. Right? We're okay with this? You have a bunch of capillary beds associated with these. Okay, yeah, see, I need to make my notes make more sense. Alright. This beautiful picture here that we were seeing, all these capillary beds next to the nephron, they're trying to be able to absorb stuff instead of filtering stuff out. So you've got all these blood vessels all over the place, and when you resorb water or salt or nutrients, whatever it is you're pulling back, there's a handy dandy blood vessel right next to it to pull it into. See that? Okay, I don't know how common the misconception is. It's a somewhat common misconception that like, oh hey, all these blood vessels are like dumping stuff out. You've already dumped stuff out in the capsule. These are here to be able to have stuff come back into the blood. Which is a little bit weird, but not that weird when you think about like carbon dioxide coming into the blood in other parts of the body. You get stuff loaded onto the blood, that's not a problem. Fair enough? These are really low pressure capillaries for the same reason that you want low pressure anywhere. You don't want this tube to have like so much blood pressure that stuff's being pushed out. You want it to be low pressure, so as there's pressure from the fluids around it, things fall in. Yeah? Okay, great. People are either bored, which is probably what I'm reading, or confused. I'm going with bored. Okay, if someone's confused, look confused with your eyeballs. Urine formation. To make urine, you're doing three things. You're filtering stuff out of the blood. So you're filtering stuff out of the blood, pulling a lot of that back into the blood, so then you're left with whatever you're left over. And then you're adding little bits of other things. Yeah, we'll go through it. It's not uncoiled like this, but schematically that's the idea. Blood coming in. So let's just watch those. We've got blood here, we've got blood here. A lot of stuff from the blood, filter. So you've got water and anything smaller than proteins are going to be leaving. Proteins and anything bigger than that should be staying in the blood. If there's damage and you're getting proteins out via urine, that's a problem. That indicates something is broken somewhere where you have holes big enough to let protein out. That's probably a problem. But water, a whole bunch of solutes coming out here. Great. And then the blood keeps going. Once we're here in the tube, you're going to pull back water into the blood. You're going to pull back glucose into the blood. Amino acids, they're smaller than proteins, right? Ions, a whole bunch of stuff. After that, you kind of check the blood and you're like, ooh, are there anything, like basically as you take out the garbage right before you go out of the house, you're like, last call, anything else that needs to go in this before I leave? You do have tubular secretion, where a couple things, mostly some ions and also some drugs, get physically put back in. It costs the body something to do this. It's not just a passive process, but you could get them out. See, this is why I need to stay focused on my time. I think we said all the things. If you're really dehydrated, so this filter works. If you're really dehydrated, you don't have enough pressure to actually form a lot of this. It's a problem. You need to be able to dissolve nitrogenous wastes in water to get rid of them. Birds don't have quite as much of a problem with this, but humans do. If you can't dissolve this waste in water and get it out, it stays in you and can make you very sick. But if you don't have the water to get that done, you're in trouble. Oliguria is when you aren't producing very much urine. We're talking less than half a liter. You should be producing more than that. If you're producing less than 100 milliliters of urine, it's called anuria, meaning you're just not making urine. People get very, very sick with that because you need this stuff to come out. I feel like I'm saying the same things over and over. I need to show you a video. And then we'll come back. Well, I think we need a video. The video is actually relevant to the whole thing. The video, it'll come in a sec. I'll show it to you here. I'll make this big. Here, let me show you this picture. I drew a grid. Note how there are some, say, things that can crystallize, right? So salt can crystallize, right? You've got calcium floating around the system. You have some drugs. You've got a whole bunch of salts. You've got sugars. You've got a bunch of things that you could crystallize them, right? take a brief moment and feel uncomfortable. What happens if you, say, form up some nice little crystal right here in the tube? Sorry, I'm using the wrong image. If you crystallize something and get it stuck in the tube, what happens next? Yeah, they're kidney stones. And the same reason you don't put gravel in your drinking straw is the same reason kidney stones are a problem, right? Like, it can clog things up, and they're pokey. I have what I think is the most boring way to explain, not the most boring way, one of the most boring ways to explain what is one of the cooler scientific concepts that have come out recently. Have you heard about using roller coasters to pass kidney stones? You're about to. But he explains it, and he's just so chill about explaining it. So, come on, sorry, my computer's having some serious technical challenges. By that I mean it just won't click. Come on. Sorry. We will come back to just the physiology stuff in a sec, but the actual anatomy part is valuable. Let me start these people, and I'll start yours. This is also, I put the words in there too. It's also a new thing for some scientific journals where they have the, like, abstract in video form, which is actually kind of nice because sometimes all you want is the abstract. Is that too loud?
Over 300,000 Americans seek emergency room care each year for renal calculi. And 1 in 10 Americans have had a renal calculi.
Over 300,000 Americans seek emergency room care each year for renal calculi. And 1 in 10 Americans have had a renal calculi.
Urologists at Michigan State University have studied roller coaster riding as a mechanism to facilitate.
For the past decade, urologists at Michigan State University have studied roller coaster riding as a mechanism to facilitate the passage of renal calculi. Almost a decade ago, patients at Michigan State University Urology reported passing renal calculi in association with riding amusement theme park thrill rides. One patient reported passing a renal calculus after each of 3 consecutive rides on the research-identified roller coaster. Eventually, a moderate-intensity roller coaster was identified as the predominant facilitator of renal calculi passage. An original peer-reviewed article has validated our pilocalyceal renal model as an excellent patient surrogate to study facilitated renal calculi passage using roller coasters. Renal calculi were twice as likely to pass with the model located in the rear car of the roller coaster. Renal calculi from all 4 renal calculi volume groups passed with roller coaster facilitation.
An original peer-reviewed article has validated our pilocalyceal renal model as an excellent patient surrogate to study facilitated.
This is a pilocalyceal renal cast. It was created utilizing CT urogram information obtained from a renal calculi forming patient. The CT information was placed into a 3D printer and this cast was produced. This is the kind of cast that was placed into clear silicone and ultimately removed. The silicone block was then resealed, filled with urine, and small renal calculi were placed within the pilocalyceal renal model for testing. This is a pilocalyceal model. It is made of clear silicone, and if you look closely, you can see 4 renal calculi within this renal model.
Clear silicone and ultimately removed. The silicone block was then resealed.
An ideal roller coaster to facilitate renal calculi passage subjects riders to quick drops and sharp turns, but it does not exceed 40 miles per hour or invert riders.
Do you see what's going on here? they got
Riding a
patients
roller
take
coaster
they
benefits
take the
renal
picture of
calculi forming patients
the drainage
only if
system,
the renal
right, where
calculi
things
can
get
pass
stuck.
through the
They make this nice
uretrovesical
little
junction
cast, and then
without
they basically legitimately
obstruction
put like
or
a handful of
undue
gravel,
distress.
kidney stones, the different sizes
Periodic
in the
roller
top thing,
coaster
and they
riding
strap this
may
whole thing in
dislodge
the
renal
back seat of a roller
calculi
coaster.
before they reach obstructive size, greater than 5
They
millimeters,
asked first.
thus reducing painful renal colic and perhaps surgery. An obstructive sized renal calculi, greater than 6 millimeters, might be dislodged from a pilocalyceal renal location when subjected to the kinds of forces observed in this study.
Subjects riders to
Roller
quick
coaster
drops
riding
and
may
sharp
offer
turns,
patients an entertaining
but
as
does
well
not
as
exceed 40
preventative
miles per hour
and therapeutic
or in
option to
riders.
medication, dietary restriction,
Riding
and
a
further
roller coaster
surgery.
benefits renal calculi forming patients only if the renal calculi can pass through the uretrovesical junction without obstruction or undue distress. Periodic roller coaster riding may dislodge renal calculi before they reach obstructive size, greater than 5 millimeters, thus reducing painful renal colic and perhaps surgery. An obstructive sized renal calculi, greater than 6 millimeters, might be dislodged from a pilocalyceal renal location when subjected to the kinds of forces observed in this study. Roller coaster riding may offer patients an entertaining as well as preventative and therapeutic option to medication, dietary restriction.
He doesn't get
and
that's
further
funny.
surgery.
It's great, but he doesn't get that's funny. Okay, thoughts or comments?
So the reason that it won't, if it's bigger than
So usually it won't pass. So if it's bigger than 6 millimeters, usually it doesn't pass on your own, and then the docs go in with either like, it's kind of cool actually. They go in with like a sonic thing. It's just like shooting sound waves at it to like shake it into little bits. If that doesn't work, they can go in surgically and like poke at things, but it's painful and invasive usually. He's saying that if you just like therapeutically ride roller coasters just a lot, you basically shake your kidneys in weird ways to kind of like clear the gunk out. You'll pass the little ones easily, but that some people have actually even passed the bigger ones. That like normally they couldn't pass at all just because normally you don't go 40 miles an hour on the rickety roller coaster. But yeah, sometimes even the big ones can pass too. I'm still deeply confused by their patient 0 who passed 3 kidney stones. He just it was he actually who went through 3 times on this roller coaster and just kept passing kidney stones. I wouldn't be at the amusement park personally. I'd be like, it hurts. But yeah, so if this is a problem, apparently riding roller coasters. They actually, sorry, I spent more time looking at this than I probably should have because it makes me deeply happy. They actually have like which roller coasters are better and worse for this for different reasons. So if you're interested, you can, look into that. But yeah. Sorry, am I forgetting something here? Yes, staying focused here. Yeah, it's caused by whatever crystallizing minerals or acids. And some people are just way more prone to this than others. Bacteria infection makes it more likely to happen. If you hold your pee a lot, it's called urinary retention. Or sometimes people don't completely void when we're going to get to urination next time. When they void, they don't get rid of all of it. The longer it sits, the more likely you're able to form crystals, right? If you have a whole bunch of calcium in your blood, this can be a problem. So sometimes people who have osteoporosis, if they've got and then they're trying to treat it, and you're trying to give lots of calcium, this now is a problem because yes, you now have lots of calcium in your blood, and you're trying to help osteoporosis, but now you're just basically forming kidney stones. And also, if you mess around with the pH of urine, the same thing can happen. But yeah, sorry. I just was boring myself. Which, if I'm bored, I figure you're probably bored, so we need to talk about roller coasters. Yeah, make sure we're covering everything. The main point of urine is, amongst other things, but the main point is to get rid of nitrogen stuff. You've dumped it out in the blood, so from the blood, you've dumped it out to filtrate. You don't want to pull it back in. Urea happens when you break down protein. It's this leftover protein chunks. It's very toxic. Uric acid comes from nucleic acid breakdown. It's also not great for you. Creatine. Remember back in muscles when you had that like little creatine store that you can use to, pay for muscle movement? That, you have creatine shows up. All these things you don't want floating loose in the body. They cause problems. So you're trying to just have them go out. The tubular excretion is going to happen for some things. Tubular reabsorption. You're reabsorbing some things really, really well. These things get reabsorbed really well. Water, glucose, amino acids, ion. Basically, stuff you want. Some of that's passive. Some of that just happens because of osmotic pressures. Some of it's active, where you're actively looking for the thing and pulling it back. And this is why I actually have this chart here. Active transports in pink. Passive transports in blue. So you're actively, so things came out of blood. You're actively pulling back sodium chloride. You're like, I want the salt back. You're actively pulling back, actually, a number of things. You're passively pulling back water, because once you pull back a bunch of salt, water is going to follow. Do you see that okay? You're actively pulling back amino acids. The nephron loop gets interesting. You have, it's very salty out here. You're going to passively pull back water. You're going to passively pull out sodium, and then you're going to, sodium chloride, and then you're going to actively pull out sodium chloride. You're going to keep pulling out sodium chloride. Basically, every time you can, you're pulling back salt. You're still going to lose a bunch, but you're pulling it back all over the place. And you, typically, with one exception, you have to pay for it. You're pulling back water passively all over the place. You're pulling back water basically every chance you get, but you're not actively moving it in, right? It's just following concentration gradients. You're actively pulling back glucose, some ions, and then these little green arrows are where you're actively pushing something out. You're actively pushing out some drugs, some hydrogen, some potassium, and that's where we're at. So this secretion is where you're actively putting it back out. Your kidneys are doing hydrogen balance, amongst other things. This tubular secretion isn't the main way to clean stuff out of blood. It's legitimately like the last check. But you can get rid of some toxins this way. You're going to get rid... This is also how the body's going to try to keep the acid-base balance of the blood. It's going to be using the fastest way to maintain the acid-base balance in your body is via the respiratory system. Well, okay, the fastest way is to have buffers in the body so that acidic or basic changes don't throw you off that much. But if you've got changes that exceed your buffering system, your respiratory system's going to cover, right? Because you can blow off more carbon dioxide, right? You can breathe faster. But if you need long-term changes for whatever, because your diet or because of where you're at or the environment you're in, the kidneys are going to regulate the long-term acid-base balance. Okay, but by now we have all the stuff that's been put in and put out, and we're going to actually just move whatever's left that we either put in or pulled out. It's leaving as urine going to the renal pelvis. And once you're there, it's going to go hit the ureters, and it's going to exit the body. But that's all we have for today. Thoughts? Concerns? You'll take your quiz. Anybody want to take it here in class? Nope. Okay. have a quiz. I'll see you on Tuesday. I feel like I'm forgetting something. Am I forgetting something? You all are remembering that you have a presentation in the lab during finals? You'll do that the Tuesday of final at 2 o'clock.